We are extremely honored and pleased to have Roland Martin, the host and managing editor of TV1's News One Now, which I know all of you watch every day. Also, a featuring role in Beyond the Lights, a great new movie that's coming out next weekend, and I hope you all see. He is going to moderate our conversation on the future of healthcare. So after last night, what happens next in terms of the significant progress we've made towards increasing our insured population, and also to ensure that people who now have access to healthcare actually access it and improve their wellness as a result. So please join me in welcoming our panel as they come, and then finally our moderator. So first I'd like to introduce Jonathan Dinesman, the Senior Vice President of Government Relations for Centene Corporation. Next we have Anton Gunn, former Director of External Affairs in the Office of Intergovernmental and External Affairs at the Department of Health and Human Services. Currently founder and president of 937 Strategy Group, LLC. Acacia Salati, who is the director for the Center for Faith-Based and Neighborhood Partnerships at the Department of Health and Human Services. She's working her way back, okay. And also Deborah Wilson, who's the president and CEO of the Metropolitan Wilmington Urban League, and also the chair of the Urban League Health Policy Task Force. Deborah. And now please join me in welcoming Roland Martin.
What's happening, folks? All righty, certainly glad to be here. Acacia's going to be coming out real soon. Certainly glad to be here. Just a couple of things. One, that's an old bio. We stopped doing Washington Watch last year. Of course, our new show is the News One Now, which is the first time a black network has launched a daily morning show, which airs on TV1 from 9 a.m. to 10 a.m. And so, and yesterday actually was our first anniversary. And so last year's been great to News One Now and TV1, and so it's been a great time as well. And also to our panelists. We are shooting this as well, so we'll see some of this on television. So Anton, don't act a fool. Don't even try to talk. Don't even try to drop any Kappa lines.
If you don't act a fool, I won't act a fool.
Don't even try to drop any Kappa lines. Don't try to talk about my football team, Texas A&M, because I don't want to bring up that beatdown we gave y'all. So South Carolina. So glad. So we will make the show. So that's how it goes. All right. So we're talking about the issue of the Affordable Care Act. We're moving into the second year of it. We had all the drama last year. And so just each one of you, just real quickly, just give us a sense of where do you think we are projected to be in terms of this. I mean, obviously it was a hot button issue. It was not a major issue during the midterm elections because after the box rollout was fixed, there were so many successes, even Republicans realized not a smart thing to run on. But what are we looking at in terms of this second year, moving towards the second year? Anybody can jump in.
So, well, thank you, Roland. First and foremost, I just want to thank you all for everything that you do. You know, obviously with the elections yesterday, everybody was focused in terms of, you know, how that impacts the ACA and just our overall, you know, government system. But the reality is when we talk about impacting communities one person at a time, it is what you all do on the ground. So thank you all so much. I mean, that just has such tremendous impact out there. In regards to the ACA, I would say, you know, that from my perspective, the one thing is it is here to stay. So with all the talk about repeal and replace, I think now that we're even past this election, I think that's going to stop. And you know, I fully expect that the ACA is going to continue to evolve. And quite frankly, I think that's a debate that we need to have because for so long we've heard that, you know, from one perspective it's either horrible or it's fabulous. But the reality is that is a tremendous piece of legislation that still has some things that need to be fixed, so it works for everybody. And I'm hopeful that's where the ACA will continue to evolve.
Yeah, my thoughts are very similar. I would say first that it wasn't talked about during the election because it is deemed to be a success with the number of people who enrolled in the first enrollment period. There's a projection that we may have another 4.5 million to 5 million people that will enroll this cycle. But really the main point is to find a way to make sure that people who got covered in the first period actually can utilize their coverage effectively. Because if they're not utilizing their coverage effectively, what's the point of having health insurance coverage if you're not able to use it in a way that helps you and your family? The other piece of it is the business side of healthcare reform is starting to take control. And what do I mean by that? People kind of forgot that healthcare is a $3 trillion a year industry, and it's 18% of GDP. So when you pass something like the Affordable Care Act that impacts every single body, it creates a tremendous business opportunity for those who are focused on business opportunities in healthcare. So you're now starting to see entrepreneurs, startup companies, hospitals, other people trying to figure out, say, hey, listen, now that we got 32 million people who will be able to buy health insurance coverage, and if they can't afford it, the government will help them pay for it. Think about that, 32 million people paying an annual health insurance premium of between $5,000 and $11,000 a year. You add up the zeros about how much money that is. And so what you'll start to see, I believe now, is that people will stop talking about it as an Obamacare or a negative thing, but people will figure out, how can I turn this into a business opportunity to grow something in my community? So that's what I see as the business opportunities from healthcare.
I'm going to come out to the business opportunity a little bit later, but go right ahead.
I would say from the perspective of an affiliate in a state that was very supportive from the very beginning, with the governor that prepared, his team prepared, we entered into a state partnership exchange, received innovation grants to prepare. We're very proactive. We still saw that there is a challenge with building a system that people aren't familiar with. If you build it, people are not necessarily going to come. And while we had great success in general enrollment, we hit about 65% of our goal in the state of Delaware. With our Medicaid population, we only hit 3%. And the realization was that there has to be a very targeted outreach to reach underserved and hard to reach populations. You can't just do the general, what's going to work for the masses, and expect that to have an impact on your more vulnerable populations. So going forward, I think, I'm hoping, and I know in the state of Delaware we were working on more targeted approaches and engaging more of the grassroots and community-based organizations to make sure that we can see success.
You know, I'm from South Carolina, so I have to tell a story, and my story is that right at the very end of enrollment, my last big trip was going to Mississippi. And I was really, kind of disheartened about going to Mississippi because I had heard all these crazy things on the Beltway and on the headlines and things like that. But I go down into the Delta and I see people very, very excited. I'm at a local community health center and I'm hearing these stories. And the head of the community health center said, listen, we've got 20,000 people who are now enrolled. That was 20,000 people who didn't have health insurance before. We do not see that as a failure. We see that as a victory. And so moving forward with the Affordable Care Act, what I want to see, what HHS wants to see is, one, that people have a good experience as consumers getting on the health insurance marketplace. People feel empowered about their health insurance. But more importantly, that we start to work on the health disparities reductions that are going on in our community. At the end of the day, enrollment is great, but that's just the first part of it. Long-term is making sure that people in our communities are not dying or getting sick from diseases that are preventable.
Now, as we approach this, one of the critical issues still is going to be, how do you reach hard-to-get folks? Because it still is a cumbersome process. It still is walking people through all the information. And so the folks in here who are going to be participating in that, trying to reach those folks, what are some of the things, what are some of the strategies that worked last time that can be expanded upon, or even new ideas this time? Anybody go ahead. Anybody just jump in. There's no sprinkler head. Just go right in.
I will will share, because the state of Delaware just released some information evaluating our success and looking at what we really needed to do. And as I mentioned before, part of that is the very targeted outreach. We realized that we did not do the job we needed to reach out to specifically the Latina Hispanic population, that we needed to be more culturally relevant and linguistic with the materials, that materials needed to be at a very, very basic reading level so that people could understand, but also we needed to incorporate health literacy so that people understand what the new coverage means. And as she was saying, they have access to care, but they actually understand what that means and how to utilize it so that we can really start looking at eliminating health disparities. So what we are working on is the more targeted approach to outreach and connecting with more of those community-based organizations at the grassroots who are working with these populations already.
So there are three things: navigators, community health assisters, and the faith community. When you're talking about going into communities, it has to be knowing who's in the community. And so nobody knows the community better than our faith and community leaders. So it's really about making sure that, in my office, we work with a lot of faith groups. We worked to make sure that they understood the information and that they were talking to people in their community. And what we realized is that it took about 4 touches. The first time you talk to an individual, they're okay, you talk to them again. But what you really needed was to interact with an individual, interact with a family about 4 times. And after that, they were able to get and were more comfortable with getting into the marketplace. Anton once said, health insurance is a personal issue. You just don't decide on Tuesday that you're going to get health insurance. You think about it. You go back and you talk to your mom. You go back and talk to your dad. You ask your husband, is this right? So it takes a process. And once we understood that it was a process, I think we were really able to, especially in the last days of enrollment, be able to get a lot of people in those hard-to-reach, vulnerable communities.
Yeah, I'll just add to that piece. What Acacia is speaking to is that people receive information better from people that they trust, people that they're in a relationship with. So if I don't know you from a man in the moon and I tell you, hey man, you gotta go buy this book, it's the best book I've ever read, you're gonna be like, well, I don't know you, dude, and I'm not gonna go buy the book. But if your best friend, your husband, your wife, your sister, your mother say, you really need to get this book because there's something in there for you that you've been talking about and I think it'll help you, you're 9 times more likely to go and buy that book. So it's about finding sources that people actually trust on the ground, really localized sources who can speak to people in a language that they relate to. So one of the things that I've been doing here lately is trying to build bridges between hip hop and healthcare, because hip hop culture is something that people are culturally connected to, broad-based. And so how do we use that thing that people are culturally connected to talk about healthcare and to get them to understand what healthcare may mean for them? So it's about those trusted sources on the ground. We learned that through the first open enrollment period, that you can't have some outside organization thinking that they're going to reach people. You really have to go to the people that people have trusted for other things in their community. Those trusted sources, you get them educated and they can share the information in a way that actually gets people to make the decisions that we need them to make, that ultimately gives them access to good quality health care.
Speaking of that, in the Nielsen study on the black consumer, it shows that African-American media is trusted twice as much as other media. What role does black media play in this, specifically as it relates to African-Americans? Because I've seen, last time you saw the television commercials, you saw the print advertisements or whatever, and it was sort of a general reach as opposed to a more tailored one to niche audiences.
Okay, I think it was 6 o'clock in the morning, and I was in Virginia, and I was speaking at I was doing a radio interview in Detroit, Michigan. We did a lot of African-American radio because we know that is a trusted messenger. People are listening to that. People are listening to gospel stations and things like that.
But here's my question though, did you do it in terms of interviews, but what was the advertising side as well? Was it a combination?
So I'll answer that and be real honest about it. This is a big conversation about healthcare reform in general and the challenges that we had. We literally didn't have many financial resources at all to do much media. So that's why you saw a very general touch of, general commercials that had people of color. We did a few in Spanish, and we tried to hit as many markets as we could with broad-based general radio and television because we didn't have a robust campaign. So to give you an analysis about what those dollars look like, so if you have an iPhone, or let's say if you have an iPad, if you own an iPad, Apple spent $180 million the year before you could even buy iPad doing marketing and outreach to try to get you to buy an iPad. Samsung spent $210 million to get you to buy the Galaxy 3 phone before you could even buy one.
Well, that's because they stole it from Apple.
Yes, right. But they still spent the money. But when we did marketing and outreach on the Affordable Care Act, all we had was $27 million to do a national campaign. And that wasn't the choosing of the administration. That's literally what happened when the bill came out of Congress, and you had this debt ceiling fight and another debt ceiling fight, and all the negotiations literally sapped us of the resources to do that. So we were forced to do what we could, which is we did lots of interviews. I mean, I remember doing Tom Joyner's show a couple times. I did one with you right before open enrollment started. I did Joe Madison, Ricky Smiley, Doug Banks. So we did as much as we could because we know exactly, as you said, that if it comes from an African-American media sources, people trust it twice as much and are more likely to respond to it. And I think because of what we did, we saw those numbers hit where we saw them hit.
They're always, obviously, critics. And you had folks who said what didn't work in this place, what wasn't effective in the state of Washington. Out of all of the states with various exchanges, which do you think was the absolute best that can be replicated to other states and pick up on?
I can give you two examples, and these are the two examples that I think are the most powerful. The first is a southern state, Kentucky. The state of Kentucky did an incredibly effective job of getting people in that state covered under health insurance. It's a rural state, Appalachia, lots of poverty, lower education, all kinds of challenges that we see in the South.
Did Grimes ever mention that?
Absolutely not.
Okay, all right.
And that's her fault. So anyway, but the governor of Kentucky, he did mention it. Not only did he mention it, he made it his mission that my last term as governor, I'm going to change Kentucky forever by making sure people get access to health insurance coverage. So one, he expanded Medicaid in his state. The second thing he did, he's ran his own health insurance exchange in the state, but he didn't call it Obamacare. He didn't call it the Affordable Care Act. They call it Connect, KYNECT, which was focused on Kentuckians. And so he demystified the Affordable Care Act and made it a local thing that people could connect to in the state. That's the first example. The second example is the state of Connecticut. The state of Connecticut, which is small and kind of compact, has lots of challenges, different communities, language issues, transportation issues in some parts. The state of Connecticut focused on bringing it down to the retail level. So you know what they did? They actually opened up storefront stores in strip malls and places in communities of color where people were, and gave people the opportunity over the whole open enrollment period to come into a store, like you go into the Apple store, and play with stuff for hours and weeks before you even make a purchase decision. So they took a page out of general consumer marketing as you get people in the store, answer all of their questions, make them comfortable, and then when they're ready to make a decision, they can go right into the back of the store, sit down with someone who can help them to enroll in coverage. So they took it to a local consumer-based level, storefront, street front, right in the communities to give people the opportunity to get enrolled in coverage.
One of the things that I have long maintained is that from the political perspective, it has been a failure of the administration to go right at the heart of largely white Southern voters and say, let's have an honest conversation. Y'all broke and your health care is bad too. Do you think that politically it makes sense for this administration to go to Mississippi and Alabama and Louisiana and Arkansas and make the case that this law, it's actually for you? Because if you have the worst places with health care, I would think that's probably a good starting point when you talk about the Affordable Care Act. But for some reason, there was this unwillingness to sort of have that really clear and in-your-face conversation.
I'm happy.
Y'all can be, go ahead, don't be scared.
I'm not scared, not at
I completely agree with you. I think that the one thing that people didn't talk about were, that this impacts everybody and it improves the lives of people that, quite frankly, didn't have opportunities for health care before. There's always these things like, when you drive a car, you have the choice to get car insurance and drive the car. You do not have a choice to stay healthy. And that is not a black or white issue. This is something that impacts all of us. And quite frankly, the other component is the cost impacts all of us. So let's get people the appropriate care in the appropriate setting. And that is something that I think the administration failed at miserably in terms of truly educating people on the value of having health care. I think at times, people focused on the complexity of the law, but at the end of the day, health care is all about getting care at the right time, in the right setting, and making sure that you remove barriers so that, the health care works for all.
As the only member of the Obama administration on the panel, I will just say these couple of things. In my community, we have a saying that a lie could go around the globe 20 times before the truth is able to tie their shoes. The fact of the matter is that there was so much misinformation out there by so many people who were paid to do it. I mean, we're talking about billions of dollars that were going out into communities. I cannot tell you the different types of rumors and misconceptions that I heard. And so many times what they did was they made healthcare this toxic thing, this thing to be feared. And it took a lot of people, a lot of trusted messengers to be able to unpack all of that, to be able to explain what the truth is. But we're also talking about a certain amount of enrollment time. We're talking about the fact that we have a certain amount of dollars. And even with all of that, we got 8 million people covered at the Affordable Care Act. I think that deserves applause. 8 million people got covered.
And the reason I'm asking, the reason I made this statement, the reason I think is important is because when we have this conversation about the Affordable Care Act, about health care, here's what I think happens. Folks go, oh, that's somebody else. Oh, so that's a handout for them. When if you look at the numbers are very clear. The states with the worst health care, the folks with the most need, and in many cases, those are red states. And I just think, and do understand, I mean, I get it, but I've told the president the exact same thing, so it's all good. And I've said, you need to go to the red states and look them dead in the eye and go in the heart of these places and say, this bill was passed for you. This was introduced for you. And the people who you keep voting for are the ones who are telling you it's not a good thing when it actually can help you and your daughters and your sons and your grandkids. Anton.
Yeah, I agree with both you and Acacia, and I'll give it in these two contexts. There was $450 million spent over 4 years in anti-Affordable Care Act ads. And when I mean $450 million, it totaled about 880,000 ads against the Affordable Care Act. On the affirmative side, it was only about 58,000 ads supporting of the Affordable Care Act because we had limited resources. So you are dealing with the lie going around the world 7 times before the truth gets out of bed in the morning. But the second piece is there are 2 examples in history where we probably could have done a better job as a nation engaging people in those areas around the ACA. When the Social Security Act was passed and people were entitled to Social Security benefits, the federal government kind of deputized every federal agency to go and find people and make sure that they enrolled in Social Security to get their benefits. So they took park rangers who were in Yellowstone and said, hey, you got 20 campers that have been living in Yellowstone for 5 years. We need you to go find those folks and tell them that they can get Social Security benefits so they get enrolled. When George Bush signed Medicare Part D into law, there was this deputization of the Social Security Administration to say, hey, Medicare recipients and Social Security recipients are the same people, so we're going to make sure every Social Security agent understands Medicare Part D, and so when you talk to somebody about Social Security benefits, tell them that they can get prescription drug coverage now because they weren't able to get that before. And so there were some things we probably could have done to reach people in those communities, but I want to take the politics out of it because we all know we're in a polarized time and that people color everything with politics. So when you sometimes see the president you immediately think in politics, not service and the benefits of what government can give you. And so some of the challenges, we had the wrong messengers on the ACA, like having David Plouffe or David Axelrod on TV talking about health care. They are immediately assumed to be a political hack, rather than have a doctor on television talking about health care, or maybe an insurance executive who understands it. So when you have credible officials talking about it, people respond to it differently than having political leaders.
May I also say something? We also are talking about this from the administration down. I'm a part of an affiliate movement of 97 urban leagues across the nation who have been advocating on the ground in our states to expand Medicare, to make sure that we're covering, that people are getting the coverage. So part of that is you think of the expression politics as local. Part of that is the local communities and states pressing their legislature, their local legislature, the governors, to say, we need to have this in our states, in our communities. So it's not strictly the responsibility from the top down.
Mm-hmm. Oh, no. That was, no, I had those questions too. I wanted to ask that question.
And I would just say one more thing. The fact of the matter is there are a huge amount of communities that economically vote for people who is against their economic best interest. They do. It doesn't matter, whether that's food stamps, whether it's SNAP, whether that's housing, whether that's, Medicaid. There are many people in the community who aren't really thinking, and they're deciding to elect politicians who are really going to cut services that they need and that they rely on. That's not an healthcare issue. That's an American politics issue. That's a black and white issue. I think that the healthcare issue has just come into the fore.
When we talk about on the ground, how do you advise people to go about the idea of mobilizing and organizing around this issue? Because I think for a lot of folks, they hear this conceptually, but then it's a question of, all right, what do I actually do? So if you were saying, each one of you, here are two critical things as a starting point for you to go back to mobilize and organize around the issue to get folks to sign up. What are they? Tell
stories. There was a teacher who, was paying $750 a month for her and her son for insurance. Some people who knew her said, you really should go on the health insurance marketplace. She's like, no, that's not for me. Finally, she did. After everything was said and done, she went from paying $750 for her and her son to paying $150 a month for her and her son. As we say in seminary, that'll preach. The fact of the matter is that you have to tell stories. When you say 8 million people, people's eyes glaze over. But when you say Miss Gertrude down the street was able to get, Medicaid, that when she didn't have it before, those are the things that are going to impact the community.
I would agree with that. We had a case in the state of Delaware where one of our pastors, who's a very well-known individual, received health care coverage. 45 years old, went in for his first checkup and discovered he was in the very early stages of prostate cancer, which they were able to take care of, and he has been one of the major ambassadors for outreach to people. It's telling the stories, and as we've said earlier, it's going to where people are and making sure that those messengers who are delivering the messages that they trust are coordinated. There are lots of community-based organizations, the faith community, lots of different partners that can come together, whether they're the federal navigators or receiving that funding or not, to make sure that every pocket of the community is getting the right message. So it's a coordinated effort from a grassroots perspective, and certainly sharing those stories.
I'll say, you asked about two things. There's a phrase that says, charity starts at home. The first thing that everybody can do to really have an impact in this on the ground is that don't let anybody that you know personally, if you have their number in your cell phone, if they live in your house, they're in your fraternity, they're in your sorority, if you engage with them on a regular basis, you should always ask the question, are you uninsured? Do you have health insurance coverage? Because we'd be surprised the people who sit right beside us every single day in church that don't have health insurance coverage. And if you know better, you should help people to do better who are closest to you. So first is find out who's uninsured around you and make sure you do what you can to help them to get covered. Then the second thing you do, as we're now in November, we're getting close to Thanksgiving and Christmas, and I know every single one of y'all on Thanksgiving Day or on Christmas is going to send a mass text message from your phone to everybody in your phone book to say, Merry Christmas, Happy Holidays, Happy Thanksgiving. Instead of doing that, send them a text message and say, if you are uninsured and don't have health insurance, go to healthcare.gov, call 1-800, I forgot the number now. You know the number, but.
Well, it helps to remember the number.
That's right, it does, but I don't do this for them anymore, so I don't have to remember it.
I thought you had it locked into your brain.
I did, but I forgot.
There clearly are going to be political challenges to the Affordable Care Act. Do you see, or what potential changes do you see as a result of last night's election? Not just from a congressional standpoint, but also in those states where you had Republican governors who beat Democratic governors.
I'm going to say there's going to be a couple things. From a federal perspective, there is no question. I think yesterday's election wasn't a vote for Republicans or against Democrats. It was a vote against Washington and what's occurring in terms of dysfunction. So now that this election is over, I think one of the things, and I'm going to be a glasses half full person here, is I think there's the opportunity for Republicans as they're seeing, potentially 2 years from now in terms of, this election didn't show that they can win a presidential cycle. Will they be willing to, number one, recognize the positives of the ACA and now start looking to try to fix some of the things that, they may see as, more challenging with the ACA? Same thing on the Democratic side. I think now there could be a willingness to actually, fix some things where they didn't want to open up a can of worms. At the state level, I actually think there's an opportunity for Medicaid expansion. It's not going to be something that is, rapid, but I think it'll still be a slow trickle. But I'll use Michigan as an example. Michigan wouldn't have Medicaid expansion today if they had a Democratic governor with a Republican legislature. That would have been a clash, and it wouldn't have gone anywhere. But when you had a Republican actually pushing an agenda through the legislature, they were able to get it through. I think you're going to see a little bit more about that. I think the other thing that we're going to see is, quite frankly, these states that have expanded Medicaid, there's a lot of money going through those states that are helping hospitals. A matter of fact, in expansion states, in terms of charity care with hospitals, it has been reduced by over 30%. And in those states that haven't expanded, it is actually increased by 10%. So there is an economic standpoint, and quite frankly, states that haven't expanded are not going to be able to afford not to expand. So I really think there's going to be an opportunity for some of these states to actually move towards expansion, but it is going to be a process.
I'll also add to his point about economic impact. Medicaid expansion is having an economic impact of about $5.7 billion on hospitals alone. So that's just hospitals. So I think the elections last night won't change anything policy-wise, but there are states where healthcare access will be much more available for people. For instance, Pennsylvania, who elected a new governor, expanded Medicaid, and I believe will also run their own state-based exchange, which will do wonders for those people in those states. I do think some of the governors who are now term limited, I think politics is local, just like it was mentioned earlier. There are some governors who have been having conversations behind closed doors. Let me just get through this re-election. I know I'm never going to be president. I know I'm not going to run for U.S. Senate. And so give me a chance to get through this election. I got 4 more years. I'll do the right thing. The risk is it won't be immediate. And the question is, if they take too much time, they're going to leave money on the table, and it will cost the states money. Because right now the federal government is funding Medicaid expansion, fully funded, 100% by the feds for the first 3 years, 2014, 2015, and 2016. So any governor that waits until after 2016 to expand Medicaid, then their state's going to have to pony up 3% of that expansion. But still, they're going to get 97% funded by the federal government. So it will be a tremendous benefit. You'll see that happen over time after this election. And so I think some governors will do the right thing, because literally there are people who are dying today in states because they don't have a Medicaid expansion. So there are lives who are being lost right now for not expanding Medicaid, and I think some governors really want to do the right thing, but politics trumps so many things, as we've always seen. Let's
talk improvements. There are always improve things. And so what do you see as potential improvements that should be made to ACA? Boy, so talking about improvements, huh?
I would say the first thing is you don't stop the fight, and you don't get blocked by the fact that some states may not expand Medicaid. Because at the end of the day, every state, due to their fiscal conditions, are looking at ways to achieve savings and improve the quality. So one of the first things that I would do, in especially a non-expansion state, is making sure that those states that don't cover everybody to at least 100% of the federal poverty level get coverage there. Because once you do that, at least everybody has an opportunity to get health care. Because, based on how the ACA was created, if you're at 100% of the federal poverty level and above, at least to 400%, there's subsidies for you to get health care. Medicaid's supposed to cover you at 100% and below, but not all states cover, for 100% below. Childless adults and other populations. So if you at least get the states to move coverage to that 100% level, everybody has the ability to get health care.
Go ahead.
Okay, and the other thing I was going to say is that we are working really hard on the website. We know that there were some issues with it, you could call it, this time around, but we're really focusing on making sure that things are more streamlined, that they are smoother, and people are able to get the health insurance that they need.
And let me say, one thing we noticed in the state of Delaware, when asked the question, how many people were able to enroll who were not insured? We're accessing healthcare.gov. We don't have that information. That's not built in, so you can't really track. One other thing I would say is we were really looking for more specific racial and ethnic breakdown data so that you can then strategize around how better to reach the populations if you're being effective, especially with those hard-to-reach populations. So if there's opportunities for us to get better data, to better then serve outreach for those hard-to-reach populations.
One major improvement, I think, could help with healthcare access in America. It's not even really about the ACA. This is really more about immigration reform. One of the things that the Affordable Care Act stipulated in the law that undocumented immigrants don't have access to coverage under the marketplaces in the Affordable Care Act, so they can't buy health insurance coverage. Now, why is that important? Because there's still millions of people who will be uninsured. And if folks are uninsured, they get sicker quicker, they die sooner, and they still cost us money because they show up in the emergency room seeking treatment anyway. So if we really want to get to universal coverage in healthcare reform, we have to find a way to cover the uninsured, the undocumented uninsured. And the ACA is not going to change. There will be no federal policy changing the ACA. The only way we can cover those folks is by immigration reform and giving people some status to be here legally or documented in some kind of way. Then they will be allowed to have access to it. So we got to get immigration reform if we really want to shore up the large numbers of undocumented. And it's more than 8 to 12 million people who are living in the United States of America but are undocumented. And so that's a cost to us all. So that's the first thing that I would say could be fixed. The second thing is I wish there was more resources that could go in those states where the governor or the state is not running its own health insurance exchange. And what do I mean by that? There are limited dollars to go to navigators in states like Texas, in states like Florida, in states like South Carolina and Georgia, because those states have said no to expanding the ACA. So when those states said no, there are only small amounts of money that can go to help people to do outreach to get people enrolled in coverage. But if you're in New York or California, the state of California got $180 million to do outreach to enroll people in coverage. The state of New York got $27 million a year for 5 years to do outreach to help people to get signed up. So if you lived in a state that supported the Affordable Care Act and implemented, there are more resources for community-based groups and faith-based organizations and nonprofits and small businesses to do outreach to people to help them to get enrolled in coverage. But in states that did not be proactive on the Affordable Care Act. There are very little resources at all, and so those folks don't get touched and they don't get access, and they may have never heard about the Affordable Care Act because they don't watch TV or don't have a cell phone and don't have anybody in their communities that are sharing this information with them.
Questions? What you got? So shy, so scared. Stand up, please.
So it was stated that the Obama administration failed in its attempt to proliferate the message of importance of getting health care coverage. I wonder if that failure also applies to the 500.
It was stated.
It was stated.
Who stated that?
This gentleman here on the left.
Okay.
My left. I wonder if the 535 members of the Congress also failed in making that statement and proliferating the importance of getting health care.
I completely agree with you. I think one of the missed opportunities was the ability, and quite frankly, it takes everybody to work together with this, but when you do such a significant change, such as this healthcare law was, I think I do believe the biggest problem was with all the hyper-partisan that is out there. This became a law that was passed just through one party, and then they owned it. So as Roland said, the president should have been out there, in those red states talking about the impact that it had on everybody's lives. I think the unfortunate part of the belief that with one party passing it, it was allowed to be sold as, Obamacare or just a democratic movement. And it really was not sold as something that improves everybody's lives, which it does. And I think from that standpoint on, it allowed for misinformation to be out there, and it's allowed for, the challenges that currently exist.
I would take it a step further and say that there were some members of Congress and some current governors and former governors who outright lied to their constituents about what the Affordable Care Act was and what it was not. And so going back to the comment about trusted resources and trusted sources, if the governor of your state or the member of Congress that you voted for or your state senator or your mayor of your city tells you that Obamacare is destroying jobs in our community and it's the worst thing for you and more people will die because we got this monstrosity of healthcare reform, people believe that information more so than they believe anything that's said by anybody else. And I literally remember watching an interview of a member of Congress who was a physician. He was a doctor. He also owned a small business, and he was doing a local television interview on his local news station, and he was basically lying about what the Affordable Care Act was and what it was not. And so you can expect that those constituents will believe their member of Congress because although they hate Washington, D.C., and they hate Congress altogether, everybody loves their congressman. My congressman is great. My congressman is perfect. So if your congressman tells you that Obamacare is bad for you and you don't need to sign up or don't need to be involved, what do you expect people to do?
Before I go to the next question, I do want to ask this. I still believe it was a mistake and is a mistake for the administration to embrace the term Obamacare. One, I don't allow it on my show. I call it the Affordable Care Act because when you watch Jay Leno, when you watch Jimmy Fallon, when you watch these man on the street interviews, where they literally interview people who say, the hell with Obamacare, but I'm down with the Affordable Care Act. When you know it's the exact same thing. I just think, again, I'm in the business of words. I'm in the business of phrases. And when you accept what was poll tested as a negative and you keep referring to it, you are essentially reinforcing the negative for free. And so I just want to get y'all thoughts on that because it's still, to me, crazy when I hear administration people say Obamacare, and I'm going, hell, it drives me crazy when the president says it. And I just think you're reinforcing a negative.
I would just respectfully disagree on that. And the reason why I say that, and I'm not speaking for anybody in the administration, I'm just speaking for myself, is that our community has always had to take insults and things like that and turn them into positive things. We're used to doing that. And the fact of the matter is, Obamacare, Obama does care. And I want to make sure that everybody knows that Obamacare is the Affordable Care Act, because when it starts working really well, I promise you, there are not going to be all these people talking about Obamacare. They're going to want to have political amnesia and then call it something else. So I want to make sure that, right now, yeah, it might be a struggle, but down the line, when people see all the great things that are happening from this bill, I want to make sure that my president gets the credit for it.
But look, and I get the spin of Obamacares, but what I am speaking of is the reality that when you're operating in a political world, in a social media world, in a bumper sticker world, in a hashtag world, that if there is something that is purposely used as a negative by your critics, and you are reinforcing that, and I know it's not the same, but to me it's no different when I hear somebody young say, no, we reclaimed the N-word. When you reinforce the negative, you're doing somebody else's job.
Yeah, I'll say this. You could see for the first 2 years, maybe 2.5 years, nobody in the administration ever referred to it as Obamacare. Nobody owned that word, wanted to embrace the word whatsoever. But again, after $450 million of reinforcing what Obamacare is, people had no context that there was a new health care law. They had no context for the Affordable Care Act. They had no context for any other word for health care reform other than Obamacare.
So so what you're saying is essentially, instead of making the effort to brand the Affordable Care Act, the decision was made to let's just go and accept Obamacare, and then we'll just explain what it is.
No, I think it was a little less of that. We didn't have the resources that outside interests had to push back on the message. So we didn't we didn't have the money to frame it. So that's one. The second point is, it became, the first 2 years was really all about policy. So nobody got signed up for coverage until basically 3.5 years in the ACA. So when you're having a policy conversation, we tried to refer to it as the Affordable Care Act. But when we needed people to take action and sign up for something, you had to get through that piece of the conversation to get them to sign up. So the easiest way to do that, to say, oh, this is the Obamacare that everybody was talking about, and this is what's in it for you. We can't sit here and have a philosophical town hall meeting about the merits of the law and the 10 titles and all the provisions under the public health section of the ACA. We couldn't do all of that. We had to say, this is Obamacare, and here are the 4 things you need to know about what you can do. So that's when the conversation kind of changed. And I do agree that it's probably not the wisest idea to do that, but when you have so much to get through to people, you got to get beyond and give people the connection of what it is, and then get them to knowing what you need them to do.
Let me say, on the ground, we felt our job was to educate people so that they were informed, and we never used the term Obamacare. We always speak to the Affordable Care Act so that people understand what it is they're getting educated about, what they're signing up for, and the fact that the Affordable Care Act is actually the name of the product.
Anyone else? All right, next question.
Yes, one question I'm curious about. What are the major business opportunities that are going to be created behind the Affordable Care Act? And what are the major business opportunities that African Americans can take advantage of, particularly as this money is flowing through our communities?
Man, you speaking to me right now, so good. So let me just say, there's so much opportunity. It's really hard for me to placate for you all of the opportunities. I would, pitch some work that I'm doing, but I'm not going to do that. I'll just kind of say this. When you have 32 million people who are going to get access to health insurance coverage, many of them for the very first time, and a significant percentage of those people are people of color, African Americans, Latino, Asians, Asian American, Pacific Islanders, people who haven't had access before. There are major insurance companies in the United States of America that are all trying to sell their product to these people. They're trying to sell it to them. But guess what? Insurance companies have very little experience and very little knowledge of how to sell direct to consumer. Because for many years, they just went to your company and say, hey, company, you got 10,000 employees. We want to give them our health insurance coverage. And the HR person at your company told you you had to sign up for this plan or this plan, and that's how you got it. But now under the ACA, people get to shop. They get their choice of plans the way they want to shop for plans. And so that means all of these insurance companies need somebody to help them to figure out how to talk to these people. And they pay marketing people, they pay consumer advertising people, they pay street teams, they pay everybody to reach customers when they need them to reach customers. So if you have a business that is focused on the African American consumer, there is an insurance company somewhere that needs your help to figure out how to enroll people in coverage. Now, the government won't tell you this because they want everybody to go to healthcare.gov. But you don't have to go to healthcare.gov to sign up. You can go to BlueCrossandBlueShield.com and sign up. But guess what? Those companies don't know how to reach into our communities. So that's a main opportunity there to help people to get connected to coverage. But if you're in the healthcare industry, there's so many more opportunities. Everybody will benefit.
The other thing I'd like to add to that is one of the things that states need to be educated on is when it comes to Medicaid, there is an economic development component to it. So if all these dollars are going to the states should be the ones that are requiring, number one, that dollars are going to federally qualified health centers, that minority businesses are getting their fair share of those dollars flowing through. Those are things that could be dictated by the states as they implement the ACA. And that's something that, I think we all, quite frankly, do a poor job about, and that is talking about the economic component and the jobs related to the ACA, because they're significant.
So 2 quick pieces to what he just said. So in Medicaid, if you're poor and low income in a state and you get access to Medicaid and you need to get to the doctor, but you don't have transportation to get there, Medicaid will reimburse people to take you to the doctor. So if you own a transportation company, you can get a Medicaid contract to transport people to the doctor, and that's a business opportunity for you. Very simple stuff. It's not major rocket science, but it's helping people to access a healthcare center. When $700 million went out to build new community health centers all across the country, well, if you want to build a community health center, you need architects, you need carpenters, you need electricians, you need painters, you need all of these people to build new community health centers. So these are all small business opportunities for people to capitalize on $700 million of investment going into communities to build community health centers and give people access to stuff. Tremendous business opportunities.
Next question.
Hi. Getting that many people access to an insurance card is an enormous leap forward in addressing health disparities. But an insurance card is only as good as the network it's on. And we know that there are serious issues with the availability and the quality of actual providers and care in a lot of minority communities. So the question that I have is, in my organization, Families USA, we spent a lot of time thinking about 2.0. Like, what are the next steps that have to happen beyond the ACA to further the fight towards achieving health equity for everybody in the United States? And I would like to hear some thoughts from the panelists on what needs to happen to be able to accomplish that.
Okay. Thanks. That is a great question. Primary care. 2 words. Primary care. It's not sexy, it's not specialized, but this is one of the things that's going to be able to make sure that people in our communities get the health equity that they need. What happens is that people need medical homes. Everybody needs a primary care provider. If you grew up, having a pediatrician, if you grew up having someone who's like an internist, you may not understand that. But for a lot of people in our communities, their primary care provider is the person at the emergency room. And so, as we were saying before, it's not just about having health coverage. In the District of Columbia, 95% of the individuals are coverageable. 95% have the opportunity to have health and coverage. But yet, you look at the health disparity statistics here in this district, and it's off the chain. One of the reasons why is that people have to have that access. It goes back to what everybody on the panel has been saying, that being able to get down into the local community, having navigators, having faith community groups, having certified application counselors, people that you understand and trust, be able to take you from now that you have health insurance, now what do? Educate you about what it means to have a premium. What does a deductible mean? What does a copay mean? All those types of things, but getting you to the point that you have a medical home, you and your family have a medical home, a primary care provider who can be able to take care of you and to be able to work to make sure that you're doing the things that you need to do 365 days out of the year to be able to help with your health care. And I just say one thing, because I know Anton's chomping at the bit. And the other thing I would just say is a National Health Service Corps. The National Health Service Corps is like the Peace Corps for primary care providers. Dr. Regina Benjamin, who is the former Surgeon General at the Department of Health and Human Services, got her start with the National Health Service Corps. So these are individuals who are also talented, but are also going into medically underserved communities, and because of that, they're getting their loans repaid, or they're getting scholarships for Medicare and for medical school.
Let me also say that one thing that the movement has been working on for quite a while is eliminating health disparities, creating health equity. In Delaware specifically, my affiliate does a lot of policy and advocacy work around this. Access alone doesn't solve the problem. So you have to look at the quality of care. We need to make sure, for example, that we know that there's been a challenge with a lot of the urban health centers, so that there is funding that can go into urban areas and make sure that there are high quality centers. We also need to look at cultural competency training for providers and making sure that you're placing the right provider. We had a situation where in a community that was largely Hispanic, they put a physician in who just happened to be available, who didn't speak the language, and you still didn't create access for people. So it's more than just creating access. And I also mentioned health literacy. And she also spoke to this, helping people understand how to access care. If you've never had insurance, and quite frankly, for many of us who've had insurance for years, if you're going to go in for a major procedure or something that's beyond just your normal, typical going in for your everyday, annual exams or whatever, you're going to look at your policy to see what's covered. People who've never had it don't understand this. So there are a lot of other elements that need to wrap around access so that we can really create health equity.
I'll add, we need more doctors, nurses, and other clinicians of color to practice. And so we have a good number now, but we don't nearly have enough for the number of people who will get access to insurance coverage. And so if we lack providers in the community, we have to build and develop more providers in that community. So your kids need to want to go into the STEM, academic framework. So science, technology, engineering, and math, because all of that will be involved in healthcare long term. The technology in healthcare, in terms of electronic medical records and how care is delivered, are tremendous opportunities for us to provide care for people in places where they lack providers. So telemedicine, using technology to give people access to services. I'm involved in a bunch of different things that are focused in that space, but we have to get more providers there. I'm actually getting ready to do a lot of work on diversity and inclusion in the healthcare workforce. That is big. We got a lot of major hospital systems and major provider organizations that aren't diverse at all at the senior leadership. So they're not making decisions that will help provide better access to people. And then the last piece is this whole cultural competency piece. You've heard that word a couple times. What that really says to me is that we need to demystify and deconstruct this medical language and healthcare language that we have. Because people don't know what a premium or a copay or co-insurance is. They don't understand those things. And so when you tell someone your copay is $25, they may not have a clue what you're talking about. But if you said your cover charge to see your doctor today is $25, they would understand what that is because they go to the club and they know what a cover charge is. But when you say copay, it doesn't make sense to people. So we have to find a language that connects to people, to their everyday lives, and make healthcare real. Because a doctor saying, I need to aspirate your lumbar, or I need to, people don't understand that, even if that doctor looks like them. So how do we use real language for people so people can understand how to help improve their own health is critical in 2.0, and we gotta have more clinicians that look like us in the communities that are providing those services, but we have to change this whole language so people can speak truth to what people need to get in healthcare.
And speaking of the cultural competence report, I have a great story. I was in the White House and I was talking to a group of people who looked like me about the Affordable Care Act. And I said, for example, my Aunt Mary Alice has sugar. So if she goes into the doctor and she asks, well, how's my sugar? And there's this look of blank incomprehension on the doctor's face, he's already created a barrier to her care. So there was a gentleman, on the side who did not look like me, who was nodding his head. And I said, Scott, do you know what sugar is? He said, of course, Acacia. I love sugar and donuts and cakes and pies and things like that. So, I mean, this is the reality. And everybody here knows what sugar means, diabetes. So.
May I share one other thing, too? Part of what we were hoping would be accomplished as well are creating better efficiencies in the healthcare system. So I know our state was working on a statewide improvement grant to come to our state to work on improving the quality of care. But as an advocate focused on communities of color and marginalized communities, we had to have a strong voice because there was an incentive built into this that would incentivize outcomes, physician reimbursement for outcomes. Well, if you are dealing with the Medicaid population, or if you're dealing with uninsured populations, you're already having challenges getting physicians to accept Medicaid. You don't want to create disincentives for people to accept these patients. So creating that type of system, we had to be that voice of advocacy to say, wait, how do we do this and still maintain equity in a system so that we're not disincentivizing those physicians who want to access those dollars for making health improvements, but we also want to make sure that they're still taking the patients that are going to have the worst outcomes because they haven't been insured. So you have to look at those types of things as well.
Question?
So this is sort of a real world or story thing. Just the Joe Blow having to, as a result of employment status, take advantage or consider this Health Care Act or underemployed. When I had a decent job, whatever my choices were, pick that, go, I know what it is, I pay. If there's something else, you know what the costs are, you know it's not going to be ridiculous. Became unemployed through whatever little rinky-dink job I had. They offered something. I took advantage of this. This was before the Health Care Act kicked in. And, the doctor was, I'm not sure if I take it or not. This is a doctor I'd previously gone to when I had a good job. So let's just go through. I had to get some tests as a result of something and ended up with a couple $1,000s in bills because the little rinky-dink insurance. So now the Health Care Act has kicked in and the employment status changed, but it was something that provided under the Health Care Act. So, okay, I'll go ahead and take it. And understanding the dynamics of choosing that, whatever little rinky-dink is offered versus going, I personally now, I prefer like a Kaiser where I don't have to go here to get my blood work done, there. How can just the Joe average person understand or get into, and I know how to look into a system and find out what works best or work the system, and you sort of mentioned this in the last question, how do you educate yourself to make a informed decision about this stuff, or even to then be able to communicate it to someone else? Because I walked someone else through signing up for something, but I mean, honestly, I haven't gone to the doctor this year for fear I don't want to go and, end up with $3,000, $4,000 worth of bills because I don't understand these new systems.
Who wants it?
Yeah, so now, Anton was saying some not so good stuff about healthcare.gov. But, it is still...
No, it's fine. It's fine. But there's other places to get information, too.
Okay, but for this lady, I'm saying that she should go to healthcare.gov, and I, too, can't remember the 1-800 number.
1-800-318-2596. I remember.
Yeah, you looked it up.
Somebody must have looked it up.
No, I remember it. I only have my phone.
Okay, so anyway. So healthcare.gov, you start there. They are able to kind of walk you through plans, because one of the things that it's important to understand is that the health insurance marketplace differs state to state. So what is available in Maryland isn't available in my home state of South Carolina, and it's not available in California. And they can kind of tell you what plans and everything and what you need. Another thing that is happening is that my office, as well as the Office of Minority Health, have been doing a series of webinars called Coverage to Care. And so it's basically breaking down all of that information. We blast it out to a lot of people in communities. I can make sure that you get on that list and you can tell other people about it, but we do it in English and in Spanish so that people can understand exactly what everybody on this panel has been saying. First, it's the access. How do you choose the right plan? And then once you choose the right plan, how do we make sure that you have the right coverage for yourself and your family?
Or you can buy my 5 DVD series, Obamacare 101 for $199. No, I'm just playing. I would say exactly what Acacia said. I think we have to remember that health insurance is complicated in general. Even if you got it on your job and you got an HR office with a benefits division that explains it to you, you don't understand what you're signing up for. I know you don't. You know, people with master's degrees and PhDs don't understand what they're signing up for. So it is not a simple subject that to be entered into lightly by anybody. It will take time to understand it. I think one of the things that you can do before you do anything is if you have a doctor or a hospital that you like to visit and like to go to, before you sign up for anything, you go ask that doctor or hospital, which insurance plans are you in the network for? Because if you want to keep your doctor, you need to make sure that they're in your network. Don't sign up for insurance coverage that won't allow you to go see the doctor that you want to see. So if they don't know, then you say, why don't you know which plans you signed up with? Somebody in your office should know, because that's the conversation that I'm having with doctors, is that you should be able to put a sign in your office and say, we are in these 9 plans that are offered on the health insurance marketplace, so your patients know which insurance you take. So that's the first step. The second step, healthcare.gov, Kaiser Family Foundation has a great website. There are lots of entrepreneurs who are putting things together to really inform people. Again, another business opportunity. When you don't know information, you'll go to anybody who can provide it to you, and you might have to pay a little bit to get it. You can get it free from the government, but there's a bunch of stuff we can get free from the government that people charge us an arm and a leg for every single day because we don't know any better. So you got to educate yourself and be aggressive about understanding what's out there, or you will end up paying on both ends, in the insurance and in the private market, for that same information that's free.
There should also be health navigators who can walk you through the different plans. That's their job, that's their role, to help people enroll and to help explain the different elements. So that would be an opportunity to sort of back up healthcare.gov and sit down face-to-face with someone who should be trained to share all of that information with you.
www.marketplace.cms.gov. There's a lot of great information on that, and there should be able to have links that can link you to the local navigators in your community, but also give you lots of resources and information on what's happening with the Affordable Care Act.
Hi, this is not a question, just a comment. First of all, thank you to the National Urine League and to all the panelists and the moderator for this incredible discussion on health care, which is important for everybody. I just want to bring up that federal qualified health centers serve populations that are marginalized, irrelevant of their socioeconomic status or immigration status. And they receive money also to help those who have documentation. So there is something for everybody.
That's correct.
Immigration reform probably will take a long time, but at least we are sure that everybody will have health care accessible and affordable for them. But I just want to say thank you for this discussion.
And yay for community health centers.
Absolutely.
Hey, Acacia, I didn't know you were in D.C. So a sister a couple of questions ago, and someone on the panel acknowledged that access does not equal equity, right? And so I'm wondering, and this question might go to Brother Antonio Yofi, about how this kind of big splash and this momentum that the ACA is going to create, or that it's already creating around business opportunities, how could we be more, is there anybody out there talking about kind of a comprehensive kind of economic development strategy that moves with the momentum, got you teed up, that comes out of the ACA, because we know that, right, the health disparity is linked to the wealth and income disparity. So just wondering if anybody is linking those two in a macro kind of way.
Me? I'm serious about that. I just did a healthcare supply diversity conference, in Richmond, Virginia last month. It was a room full of people who have companies, supplier diversity operations that support hospitals, insurance companies, and they all already do business in healthcare. But I basically give a talk, a broad-based talk called WTF Healthcare Reform. And WTF stands for What's the Future of Healthcare Reform? And I use it as an opportunity to dialogue about the macroeconomics of a $3 trillion a year industry that's 18% of GDP, that people have been making money for decades upon decades. And now because of the ACA, it really just moves the deck chairs around to allow new people to provide opportunities in healthcare. So you can go to AntonGunn.com, okay, sign up on my email list and see where I'll be traveling to next. I'll tell you the next 2 engagements is I'm going to Birmingham, Alabama for a pharmaceutical company conference to do the same thing there. And then Torrance, California, Sodexo is bringing me out for their Better Tomorrow Summit. So I literally will come to your organization anywhere in the country and be happy to give a talk about the future of healthcare reform and what these macroeconomic and development and business opportunities are. Well, that's great. So my strategy is linked to the fact that the customer base is new and diverse. They're poor, they're Latino, they're African American, they're people who traditionally have been locked out and priced out of the healthcare market and out of the system, but now are coming in unprecedented ways because they get access. And so because of that, that creates opportunities to reach people in those communities, and there are tremendous numbers of entrepreneurs who are effective at reaching their own communities. And so that is a broad-based strategy that I use.
I would also look at your state Medicaid programs. I'd use Illinois as an example. Before any health plan can even contract with the state, they need to have a certain percentage of minority-owned businesses that they're contracting and working with. So I think it's another opportunity to look at as well.
Last question.
Yeah. Okay, so Roland, I'm going back to something you said earlier. I just moved here from Miami, and we were at the Caleb Center. I was the editor at the Miami Times, and we had all these people there, and at the end of the day, very few signed up. In fact, very few understood what was going on for the whole day. And so our job was to try to translate it in the paper, which was equally frustrating because I didn't know what they were saying. Now I'm in a place where there are 3 states, DMV, working with the informer and trying to, again, share the information. And I continue to hear you press me to go to www anything when I'm at the library working with brothers that don't know how to sign on the computer. So that's not helping them. They don't read the paper, so I'm trying to get them the paper. Give me something that's going to help explain it to all these people that you say there's all these folks uninsured and you want us to reach out to them. But I still don't hear something that Roland was at. Give me something I can get to the brothers. Help me out because it's not working the way we're doing it right now.
All right.
Anthony,
who wants to take it?
Brother? You go ahead. You go ahead. No, you go ahead.
Well,
y'all gonna flip a coin?
No, I would just say the first thing is you should write this phone number down. Okay, because it's a 24-hour, 7-day-a-week. You can call it at 3 o'clock in the morning or 3 o'clock in the afternoon, and somebody will talk to you on the phone about the health insurance marketplace and what the Affordable Care Act is. And that number is 1-800-318-2596. 24 hours, 7 days a week. There are people who will educate people about the Affordable Care Act. You mentioned the libraries. We actually have a partnership with public libraries where we did a lot of education and training with librarians because people go into the library and ask all kinds of questions about public benefits and services, and there are librarians who can educate and explain the ACA to people in their local communities. Again, these local navigators, if you got an urban league in your town, it should be somebody at the urban league in your community that can explain the Affordable Care Act to you and what this opportunity may mean for you. So there are organizations that exist in communities. But I will tell you, what you should do is become the expert yourself. And you can do that easily by signing up for one of these multiple trainings and calls that CMS holds regularly to teach people through webinars what the ACA may mean. They do it through conference calls. They do it through a lot of means where you can get yourself to a place of education that you're proficient enough to help other people understand what this is. It is a lot of stuff. And it is confusing and it is hard because insurance is complicated and confusing and hard. It's never going to be as simple as go to Foot Locker and buy a pair of Jordans and they got size 9.5. It's not going to be that simple. It is going to be complicated. So you're going to have some patience. You're going to help raise the level of people to understand what this means and how this actually works for them.
All right, then. And with that, this panel's a wrap. Panelists, thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you.